We've just had an election, and whatever the disagreements between the parties, the NHS was most definitely on the ballot paper. Voters told the pollsters time after time that their most important issue was the future of a service that is part of the very essence of our country. My party showed its commitment to the NHS then by pledging £8 billion to fund the NHS's own plan for its future, showing that you can only have a strong NHS with a strong economy. That came after a challenging 5-year period in which we honoured another pledge to protect funding for the NHS when the budgets of every other big department were cut. But our commitment goes back further. Conservatives have been responsible for the NHS for more of its history than any other party. Indeed, although a Labour government set up the NHS in 1948, it was a Conservative health minister, actually a coalition Conservative health minister, Sir Henry Willink, who first presented a white paper to the House of Commons in 1944, arguing for the setting up of a National Health Service, strongly supported by Winston Churchill. We did this because we are passionate about what the NHS stands for. The belief that the highest ideal for any civilised society is to offer its citizens access to high-quality healthcare, irrespective of means. The instinct that we should always strive to ensure the horror of disease is never compounded by financial worries on top. And the confidence that comes from superb NHS care experienced by our own families. And I speak as a proud dad for whom the NHS has delivered 3 wonderful children in the last 5 years. I'm today taking a bold step to set out the direction of reform for the NHS, not just for the next 5 years, but for the next 25. Now, every health secretary has to deal with a crisis of some sort. And my first was not long coming. The Francis report into the horror of what happened at Midstaffs shocked me to the core. How could a system which claimed to put patients first allow such lapses in care to continue for 4 years without anyone putting a stop to it? It was quite simply a total betrayal of what the NHS stood for, not least a betrayal of the staff who worked in those hospitals. Notwithstanding Midstaffs, we have much to be proud of in our NHS. The universal access that it pioneered, progress on reducing waiting times, improving cancer survival rates, dementia and mental health care, strong primary care traditions, R&D, medical education and training, and our high rating from the Commonwealth Fund. We also have an excellent 5-year plan for the NHS developed by Simon Stevens, which, as we saw from the budget last week, this government is willing to support financially on the back of a strong economy. But alongside a plan, we need a vision. And that vision encompasses many things: the move from a narrow focus on access targets to a broader vision of what high-quality care entails, the change from disjointed episodic care to holistic integrated care, the move to prevention, not cure, with a much bigger focus on public health and more personal responsibility for our well-being. But running through all of these things is a fundamental shift in power from a bureaucratic system where power sits in the hands, ultimately, of politicians, to a democratic system where the most powerful person is not the doctor, the manager, or even the health secretary, but the 1 million patients who use the NHS every 36 hours. My argument today is simple. If we truly want to change from a bureaucratic to a patient-centric system, the NHS needs a profound transformation in its culture. Now, patient-centric is a pretty horrific phrase. How about more human? The title of Steve Hilton's recent book. Because the truth is that decades of building processes around system targets and system objectives, often with the best of intentions, has demoralised staff and patients and dehumanised what should be one of the most human organisations that we have. Just look at some of the metrics we track. Avoidable deaths is one of them. And how many are there? Around 800 every single month. That is 800 human beings who have not been treated with dignity, care and respect, with catastrophic consequences. Another metric is never events, the clinical mistakes that are so bad they are simply classified as things that should never ever happen. One of those never events is wrong site surgery. But how many people know that in our system, twice a week on average, we operate on the wrong part of someone's body? The NHS is by no means unique in this, and arguably it's facing up to these issues better than many other systems. But a more human system would not tolerate them at all. So how do we change this? As with any illness, the first step is an honest diagnosis. And I call this intelligent transparency. As we've rolled this out over the last few years, there has been some fairly predictable opposition. Some worried that openness about failures would lead to an irreversible cycle of decline. Others said it would damage morale and staff retention. When I stood up in the House of Commons 2 years ago and said that care was unsafe, not just at Mid-Staffs but at 11 other Keogh hospitals, political opponents called it running down the NHS. In fact, the opposite happened. Following the Keogh report and the work of our outstanding Chief Inspector of Hospitals, 21 trusts, that's 15% of all acute trusts, have been put into special measures. And did staff drain away from them? On the contrary, between them they hired an additional 125 doctors and 871 nurses. 7 of those trusts have already come out of special measures, and nearly all have shown dramatic signs of improvement. Many of these trusts talk about a dramatic change in culture too. As one nurse at Basildon said to me, if we have a worry about patient care, now they listen to us, before they didn't. But this isn't just about hospitals. We've pressed on with intelligent transparency for care homes and domiciliary services, where so far nearly 3,000 of 5,000 inspected have been classed as good or outstanding. And next March, we will go further still, becoming the first country in the world to publish avoidable deaths by hospital trust, and with the help of the King's Fund, publish ratings on the overall quality of care provided to different patient groups in every local health economy. Building on the success of the Friends and Family Test, patient experience will be a critical element of how these ratings are constructed. Nigel Lawson, formerly Chancellor, famously described the NHS as a national religion. The problem with religions is that when you question the prevailing orthodoxy, you can end up facing the Spanish Inquisition. NHS orthodoxy was that criticism should not be made public because it would damage morale. We now see that was wrong. Intelligent transparency is becoming a reformation moment for the NHS as the public appreciate that a system with the confidence to be honest about failings is a system that does something to put them right. And that means honesty with the public about their responsibilities too. Not just over the appropriate use of NHS resources, which is why we're going to put indicative pricing on the outside of the more expensive medicines, but also the responsibility each one of us has for our own health and those of our families. Nearly half the parents of obese children do not even know their child is overweight, even though the subsequent impact in terms of mental and physical health is beyond doubt. Intelligent transparency means an intelligent conversation with the public about the role we all need to play to make ourselves a healthier nation. Transparency over outcomes also makes possible true devolution of power. Every health secretary, of whichever party, arrives in office committed to local decision-making. horrified no doubt at the prospect of Nye Bevan's bedpan from Tredegar reverberating around the Palace of Westminster. But then there's a flu epidemic, a care scandal, or an A&E nightmare, and they discover their inner Stalin as they rush to bang heads together. But if you have independent, smart measures of performance, area by area, hospital by hospital, a health secretary can relax a little. You can start to devolve power, safe on the basis not just of earned autonomy for people delivering good quality care, but because where there are problems, many of them will self-correct. With smart metrics, we can also be less prescriptive about models of care, allowing more space for local ingenuity and innovation. We need to move further and faster towards Valencia-style population-level commissioning with accountable care organisations or integrated care provision as planned in Greater Manchester with Devo Mank. And as we make these changes, we can be officially neutral about whether one part of the country is trying a local authority-led solution, just as another tries an acute-led model and another a GP-led plan. All will be assessed and held accountable through the same sensible, clear metrics. All can learn from each other. And with great relief, we can consign to the dustbin the idea of continually rolling out new models from Richmond House as local bottom-up solutions take the lead. To power this, we need to foster an inquisitive, curious, and hungry learning culture. The world's 5th largest organisation needs to become the world's largest learning organisation. So today I can announce that the operating name for the new jointly led Monitor and TDA will be NHS Improvement. I'm also delighted to announce that Ed Smith is to be the new chair, supported by Aradazi as a new non-executive director. Ed will launch a recruitment process for the new chief executive immediately, which will be completed by the end of September. I'd like to take this opportunity to thank Baroness Hannam, David Bennett, Peter Carr, David Flory and Bob Alexander for their outstanding service to the NHS over many years, for which we are incredibly grateful. Because safety and quality will be at the heart of the new organisation's remit, Dr. Mike Durkin's safety function will move there with 2 early priorities. Firstly, to work with the Chief Nursing Officer to complete the work started by NICE on safe staffing levels. There can be no compromise on the issue of safe staffing, and we need a methodology that properly assesses and publishes what appropriate levels of staffing should be, taking full account of the changes that can be made with new technology and modern multidisciplinary work practices. This will be independently reviewed by NICE, the Chief Inspector of Hospitals and Sir Robert Francis to ensure that it meets the high standards of care the NHS aspires to. And secondly, Dr. Durkin will set up a new independent patient safety investigation service modelled on the air accident investigation branch used by the airline industry. A no-blame learning culture in that industry has led to dramatic reductions in both fatalities and cost, and we now need to do the same in healthcare. To further strengthen a culture of continuous improvement, we have to be open to insight and expertise from across the globe. I can therefore announce today the start of an international buddying programme. 5 NHS trusts, Surrey and Sussex Healthcare, Leeds Teaching Hospitals, University Hospitals Coventry and Warwickshire, Barking, Havering and Redbridge, and Shrewsbury and Telford, will from this year be partnered with Virginia Mason Hospital in Seattle, perhaps the safest hospital in the world. We won't stop there. If we want to be the best, we must learn from the best, whether Kaiser Permanente in California, the Mayo Clinic, Alzira in Spain, Apollo in India, or anyone else. And I look forward to developing further international partnerships over the months ahead. Game-changing innovation is not sustainable without strong leadership, as we know from the excellent Rose Report, which I'm also publishing today. In line with its recommendations, the national responsibility for nurturing and developing talented leadership in the NHS, including the NHS Leadership Academy, will be brought together and become the responsibility of Health Education England. However, as that report makes clear, every single NHS organisation will be responsible for nurturing the next generation of leaders. As we said in our manifesto, we are considering how best to recognise and reward high performance. I'm also publishing Professor Sir Bruce Keogh's Progress Reviewing the Professional Codes of Doctors and Nurses. He says that whilst there has been some improvements, more work needs to be done on incentives so that, like the airline industry, the default option is openness and not reticence when dealing with errors. Taken together, I want these changes to create a profound change in culture in the NHS. And this is my offer to the NHS today. More transparency in return for fewer targets. Learning and continuous improvement at the heart of a more human system where we eliminate any conflict between organisational priorities and what's right for the patient sitting in front of you. One litmus test of our commitment to this approach is 7-day care. But this is not about increasing the total number of hours worked every week by any individual doctor. Doctors already work extremely hard, and their hours should always be within safe limits. But we will reform the consultant contract to remove the opt-out from weekend working for newly qualified hospital doctors. No doctors currently in service will be forced to move on to the new contracts, although we will end extortionate off-contract payments for those who continue to exercise their weekend opt-out. Every weekend, swathes of doctors go into the hospital to see their patients, driven by professionalism and goodwill, but in many cases with no thanks or recognition. The aim is to acknowledge that professionalism by putting their contributions on a formalised footing through a more patient and professionally oriented contract. And as a result of these changes, by the end of the Parliament, I expect the majority of hospital doctors to be on 7-day contracts. Around 6,000 people lose their lives every year because we don't have a proper 7-day service in hospitals. You are 15% more likely to die if you're admitted on a Sunday compared to being admitted on a Wednesday. No one could possibly say this was a system built around the needs of patients. And yet when I pointed this out to the BMA, they told me to get real. I simply say to the Doctors' Union that I can give them 6,000 reasons why they, not I, need to get real on this. They are not remotely in touch with what their members actually believe. I have yet to meet a consultant who would be happy for their own family to be admitted on a weekend or wouldn't prefer to get test results back more quickly for their own patients. I won't allow the BMA to be a roadblock to reforms that will save lives. There'll now be 6 weeks to work with the BMA union negotiators before a September decision point, but be in no doubt, if we can't negotiate, we are ready to impose a new contract. We have the chance to make NHS patients the most powerful patients in the world, and we should leap at the opportunities. Within the next 5 years, our electronic health records will be available seamlessly in every care setting. You'll be able to access them, share them, mark preferences and shape the care you want around them. We'll be decoding individual genomes, allowing us to target personalised medicines, improve diagnosis and therapy and reduce waste. New medical devices will mean an ambulance arrives to pick us up, not after a heart attack, but before it, as they receive a signal sent from a mobile phone. Intelligent transparency creates intelligent patients with healthier outcomes. Get this right, and it's no exaggeration to say the impact will be as profound for humanity in the next decade as the internet has been in the last. And I want the NHS to get there first. So last September, we launched My NHS, where patients can see information about the quality of services provided by hospitals, GPs, surgeons, and local authorities all in one place. Last year we also increased the number of GPs offering patients access to their summary medical record from 3% to 97%, alongside the ability to book appointments and order prescriptions. 2.5 million patients have activated this service so far. But we need to go much further, and today I want to highlight 3 areas in particular. Firstly, we need to make sure that patients really are in a position to do something about the information they now have for the first time. Real patient power isn't just about knowledge, it's being able to act on that knowledge so that those providing care feel financial as well as operational consequences. So from next year, as part of the new electronic booking service, which has replaced Choose and Book, all GPs will be asked to tell patients not just which hospitals they can be referred to, but the relevant CQC rating and waiting time as well. Because these ratings now include patient experience, safety and quality of care, patients will for the first time be able to make a truly informed choice about which local service is best for them. Patients also need to be able to make a meaningful choice about which GP surgery is most appropriate for their needs. Right now that's not always possible because practices get full and there's a lack of capacity. So we'll address this through our new deal for general practice, which will boost GP provision in under-doctored areas, with NHS England giving particular attention to making sure there are alternatives available when a practice has been rated inadequate. But patient power is not just about being able to choose the right provider. It's also about being able to choose the right service within each provider. In 3 areas in particular, we still too often tell patients what service is available on a take-it-or-leave-it basis without allowing them to choose what's most appropriate for their needs. So today I can announce that before the end of this year, NHS England will come up with concrete proposals to make sure there is a meaningful choice and control over services offered in maternity and end-of-life care and for those with complex long-term conditions. Finally, if we're to embrace the potential for technology to shift power to patients, we need patients to be willing and able to harness that technology. Digital inclusion is as vital in healthcare as everywhere else, not least because some of the greatest impacts of new technology in health is with the most vulnerable patients. I've therefore asked Martha Lane Fox to develop some practical proposals for the NHS National Information Board before the end of the year as to how we can increase take-up of new digital innovations in health by those who will benefit from them the most. The forward view sets our course for 5 years, but transition to patient power will dominate healthcare not just for the next 5 years, but for the next 50. We cannot resist the democratisation of healthcare any more than we can resist democracy itself. But we can choose whether we want the NHS to be the leader in the pack, turning heads across the globe, or a laggard, always struggling to embrace innovation adopted earlier elsewhere. Starting with intelligent transparency, then using it to foster a learning culture to support and empower staff, then embracing technology to give patients real control of their own health and care. That is the journey that beckons. The world's largest learning organisation supporting the world's most powerful patients. Time to get real to the opportunity and rush to embrace it. Thank you very much.